Welcome to the Psychotropic Deprescribing Council's webinar series. My name is Adele Framer. I founded the PDC to advance safe, responsible, patient-centered approaches to deprescribing and tapering psychotropic drugs, which include antidepressants, benzodiazepines, and pain drugs. We believe that deprescribing psychotropics should include the intention of recovery and support for it when needed. It's not just about reducing medication, it's about moving towards a better quality of life. Today we are pleased to present Dr. DeLon Canterbury. DeLon is a board-certified geriatric pharmacist who has done something unusual. He directly assists patients in reducing unnecessary medications. He'll be speaking about how, as a pharmacist, he realized he wanted to open a private practice, how he designs a taper schedule for his clients, and how he works with their treating physicians to accomplish gradual tapering of psychotropic drugs. He will also cover a case study of deprescribing benzodiazepines for an 80-year-old woman. DeLon's talk will be followed by a short question and answer period. Thank you to everyone who has donated. Your gift makes it possible for us to continue activities like these. Thank you for your time and attention.
Good afternoon or good morning, everyone. It's such an honor and pleasure to be here. Yes, I am excited and passionate about deprescribing. Thank you so much for the lovely introduction, Adele. And it's amazing to be here. So let's hop on to it. I'm going to go ahead and share a presentation and we'll dive into the world of how we all can become our very own deprescribing advocate. So again, this is strictly for educational and, of course, any information here today shared with a clinical regard, you can discuss with your provider. Had the pleasure of meeting Adele fairly recently at this last U.S. Deprescribing Research Network conference, hosted as a part of the American Geriatric Society in the beautiful city of Chicago. And we kicked it off not only around like-minded people who look into the research of deprescribing, but I like getting into the actual doing, right? Like, how do we bring this much needed service straight to our aging community? And I love the work we see globally across the world. But I realized, pharmacists have a secret weapon. We already know the drugs, so let's find a way to bring it to the people that need it most. So today we'll dive into my creation journey, like what got me into starting geriatrics and how we are changing the landscape of the aging industry one patient at a time. So what do? Geriatrics is a concierge medication safety service, right? We focus, of course, on a bit of deprescribing, but we more want to advocate and train our caregivers about the power of deprescribing and the power of having positive conversations and collaborative approaches with your prescribers, okay? We know that polypharmacy, overprescribing, et cetera, is a systemic issue. And there are ways to integrate amazing, brilliant, aging-friendly pharmacists into the equation to combat preventable harm from medications, okay? So in 2020, I came up with the idea of, let me leave the traditional retail model we have in pharmacy as a pharmacy manager, and let's dive into the world of working directly for the most important person, the caregiver, right? The person who's navigating a complex system. And the last thing they want to assume is that all their medications, of course, may have some type of harm. That's the last thing one person wants to think about. So thinking about what I saw in the traditional pharmacy world, I realized, we all need a pharmacist. Let's have someone who does the opposite of filling pills every day and coach people how they can holistically get off of medication safely with medical supervision. So since starting, we've hit the ground running with working in senior living communities. We've done talks for the Alzheimer's associations, Parkinson's associations. We like to collaborate with tons of nonprofits and really meet people where they are, right? And take, of course, the headache out of healthcare. So why do we do this? Most of our treatments involve some type of medication. About 80% involves some type of drug in all aspects of a person's life. Yet only 13% of primary care physicians consult with a pharmacist before writing a new prescription. We tend to wait till the last moment or in the healthcare timeline where our pharmacist is the last person giving that med between a patient and hopefully better outcomes. So that being said, we aren't really using pharmacists, I feel, to our fullest potential, right? We're kind of waiting for things to happen and we're hoping it goes through insurance. We're hoping it's covered and we're hoping it doesn't cause any fatal reactions, right? But I think that's a little bit too late. What if we had a model where we incorporate pharmacists with the prescriber and have meetings prior to that orders sent? And hopefully we can maybe minimize any aging-friendly related harms from drug interactions. In this country alone, we have 750 older adults hospitalized every day just because of a medication-related event. And with a growing population, almost 11,000 people turning 65 every day, who will become the champion for medication safety in this aging population? I'll tell you who. It's going to end up being you, the caregiver, right? Clinicians are already mired with tons of other competing priorities, and it's going to ultimately come down to either the patient advocating for themselves or a concerned loved one doing the heavy lifting. So geriatrics is here to take off of that burden, come with a professional pharmacist expertise, and give you quick and easy ways to advocate for reducing potentially inappropriate medication use, especially in our most vulnerable population. All right. So let's get into it. I ended up moving here to North Carolina. I'm in Durham currently. We service clients all over the country with our medication consults. But I moved over here to attend pharmacy school at UNC, Eshelman School of Pharmacy. Go Heels. And that being said, I got into pharmacy because my family, my mom, had a huge passion for herbalism and natural products. And it got me excited to know more about how do these plants, how do these remedies work on the body, right? That got me into pharmacy. With my Caribbean roots, and that's all we had. We didn't have a pharmacy nearby. We would make some type of herbal concoction and we would use that. And it got me excited about how do medicines work. Of course, on the screen, you may see a different picture of me in pharmacy, but what got me smiling most here were doing community events. I love doing events in schools. I like doing, workshops and doing career days for middle schoolers, teaching people about the power of a pharmacist and advocating for the marginalized. That's a really big passion of mine. Paying homage to my family who came from, a developing country in South America, Guyana. But that being said, I learned very quickly that the business of pharmacy didn't really align with the profession of pharmacy, especially coming from the setting of Walgreens, where I was a pharmacy manager for quite a couple of years and had to learn very quickly about the profit and loss margin sheets and what we need to push to make revenue and quotas that frankly did not quite relate or translate to patient well-being. That being said, once I got down to the business of it, I realized very quickly this is not what I went to pharmacy school for. Don't get me wrong, it was fun being a trusted part of the community, having people come with their problems and solving them for them and advocating for them. But at the end of the day, the pill for every ill model just did not align with my spirit and with what I felt our calling was meant to be. So it did get me into a world of depression and anxiety. And I ended up taking my own set of benzos along with other SSRIs to manage the stress of working in this environment where I'm, coming out of school, I've got a fair share of student debt. And here I am wondering if this is my life sentence to standing up, hunching over and being yelled at a drive-thru as if I'm at a McDonald's. And I don't think that aligned well for, what I wanted to do. And hence the frustration, the depression, the, essential sense of hopelessness. And I'm not the only one. How many of you guys may wake up and you just don't have that spark in your step? You don't have that passion for what you thought you wanted to do. And that's how I was seeing my profession. And so ultimately, yeah, I did feel like a passenger in my own life, and especially working in the humble city of Henderson, North Carolina, which was primarily older population. I found that, there are a lot of older adults on a lot of pretty high risk medications. And I wasn't quite geriatric trained, but having worked with a number of them, I'm seeing duplicate benzos, many psych meds, and even if I make notes and advocate and call the providers, I'm wondering, is my role as a pharmacist actually causing more harm than good? And it did lead to a kind of an existential crisis for me. Is like, is this really helping people in the long run when I feel there are other ways to heal, right? So what did I do? 2017, first and foremost, I decided to learn more about who I'm helping. I got my board certification in geriatric pharmacotherapy in 2017. And then eventually in 2020 or 2019, I stepped down from Walgreens and decided to do what I love most. I got involved with the community right here in Durham and volunteered as a ship counselor for a senior pharmacist. I worked with the African American COVID task force, dispelling vaccination myths during the height of the pandemic. And I ended up working temporarily as a poison control pharmacist, right? So all of this happened in 2020. And eventually I learned that I just need to be with people directly, and had a gift for making complex things make sense for your common man. And I found, the most important thing that I do every day is I found that joy back, right? I found that passion for pharmacy by being a judicious steward of information, especially in a time of crisis where we didn't know what was happening with vaccinations and testing. But another side to this story on why I started geriatrics starts with my grandmother. My grandmother, Mildred, had dementia, moderate to mild, and was being treated in an assisted living in New York. And during my time, this is, mind you, an undergrad about, I'd say a few years prior, we noticed that she was sharply declining and the assisted living could no longer take care of her. And so we ended up, my parents, that is, in Atlanta, moving Granny Mildred down to our family home. My mom, Sandra, is a teacher. My dad is an accountant with his own business. So they're not exactly, clinically trained people, right? And so they've had to jump 10 toes into caregiving while raising 3 kids, right? As we know, the sandwich generation is growing and growing, and we all can relate to being, a little concerned about, how your parents or your loved ones are doing. But Granny was getting worse. And I mean, we were following the directions of the provider. We were, doing what we were supposed to, but her dementia led to her having more wandering around the house, losing many of her dentures and glasses, how pricey those can be, more forgetfulness, more confusion. And ultimately, our parents just became more frustrated and could not really keep up with keeping Granny at home. It was that my mom, who had a refill at a local store, who really just shared her frustration about the decline. And the pharmacist, this community pharmacist, I will say, took the time to review the medications, stop what she was doing. And then I realized that one of the medications she was taking was an antipsychotic. And it was an antipsychotic that was FDA black box warning for any use in people that have dementia. And yes, my grandmother was having some psychosis with her dementia. So this was an old school antipsychotic. I think it was ziprasidone or Geodon. And we had that pharmacist advocate for us. She called the doctor. She came up with a tapering schedule. And Granny Mildred got back to her, kind of normal, mild dementia self in just a matter of 2 to 4 weeks, right? So guys, ladies and gentlemen, what's the point of this story? Apart from her being the inspiration for me being here today, and being that pharmacist who saved my grandmother's life, why the hell did it take so much time and energy? We're talking months of caregiving for one person to realize that this medication was the crux of all the issues, right? I mean, she was able to live gracefully to the beautiful age of 90 about 8 years after this event happened, right? And happy as can be and cognizant, right? She was remembering us. She was making jokes. But here we are in a world where we're thinking, we've got the best healthcare, we're waiting for a train wreck to happen. And it shouldn't take this last minute effort for, that pharmacist to become the only voice in my grandma's journey who's had multiple providers, multiple clinicians that touch her. Why did it take so long? And that really was the brainchild behind me creating Geriatrics Today. So in that same vein, I decided, let me leave pharmacy. I'm going to work for families. So we use a subscription model service. It's a cash-based service. It's private pay. We focus on precision medicine or genetic testing. We look and also provide prescribing advocacy. So all the work and research we do in studying the leading evidence around prescribing, we incorporate that into our practice. And most importantly, we advocate for the family. We start with what matters most to you and your loved ones, right? We incorporate the aging-friendly mantra where we use the 4 M's approach in all of our consults, leading with what matters most. How are we preserving mobility? How are we preserving mindset? And of course, how are we looking at the medications to make sure they don't conflict with any of the 3 goals we just mentioned? That's the power of having your own prescribing pharmacist and incorporating cutting-edge information into clinical practice. So I will share one of our hallmark cases, and this was a very, very first case we had received as a company with geriatrics. We've got an 80-year-old woman who has presented with chronic constipation, increased confusion, worsened memory loss, irritability, no energy, and some dry mouth. Her daughter, who's the adult caregiver, described her as being a walking zombie over the last few months. Unfortunately, the patient had her husband die in the last year and had a little bit of depression. Okay. So this woman came to us at the referral of another pharmacist, and this was her mother-in-law who was the caregiver. So on first glance, this is the medication list, right? This was what was sent to me, electronically. And, we've got a couple of psych meds here. We've got a couple of over-the-counter meds. If you start looking closely, right, you'll notice that there are some patterns in how she's taking some of these. And, I'll let people, if you can, put in the chat, what are some things that jump out to you? Are any of these meds familiar to you? Are there any medications you've had, some successes with, or maybe some concerns that you would have? If you were coming in and this was your loved one presenting with these very same symptoms, what questions would you ask? Where would you start? Would you start this conversation with the provider? Would you start a conversation with the caregiver? Would you start questions with the patient, right? What are your thinking? So I'd love to know if you have anything in the chat, you could pop it in there. So looking at this, we've got someone who's been on Klonopin 2 milligrams, mainly being used for sleep and some anxiety. And she misses 2 doses a week. I wish she missed more, but no, 2 milligrams could be quite a hefty dose for an 80-year-old, right? We've got some blood pressure meds on board, a couple allergy meds. There's gabapentin being used nightly for nerve pain, although it doesn't help her pain. So, I want to know what you guys have thinking. We know gabapentin can be sedating. If it's not working, why are we using it? So asking these probing questions as we're reviewing the case helps build evidence for us to provide kind of a medication safety consult as we provide this for her main prescriber. Okay. She had a seizure maybe 9 or 10 years ago. It hasn't been reassessed for it since. So the Keppra we thought was necessary at one point. Later on, we realized it didn't really make sense. Tamsulosin. Why is a female patient on tamsulosin regularly, right? And of course, for acute kidney issues, it can make some sense, but for just general bladder retention, completely inappropriate for long-term use, right? So again, a lot of this information came from having a deep conversation with both the client and the caregiver, all right? But I got some bad news, guys. That was not her complete medication list. She also was taking a slew of over-the-counter medications and also had some medications she didn't know if she was supposed to stop or switch. So there was some hangover from some previous clinicians involved in her care. At the end of the day, she was taking close to 30 medications, and eventually, after our consult and after coming up with tapered regimens and identifying a number of issues, duplicate therapies, prescribing cascades, tons of misappropriated drugs, we realized that she didn't need most. And we got her down from 36 medications down to about 8 medications in about 2 months' time with her provider's collaborative efforts. Okay. So I feel this, again, resonates a bit with me, as it is a little similar to what happened to my grandmother. This was indeed the very first client we had. And to add to that, you also learn a bit more about some of the dark side we see of aging. And this woman was fairly affluent. Her family was not convinced that it was the medications causing her dementia. And so outside of the caregiver who hired us, her other family wanted to put her into a memory care home and essentially seize her assets, make her look as if she doesn't have any ability to make her own decisions, and they'll be able to take her home and take whatever she had in the bank. And the beauty and sadness about the story is we were able to present the very same information we did in our report of this to a court of her peers. And we were able to get the court involuntary commission dropped. All right. So that means they did not have to force her into a nursing home because we were able to prove that it was medication related. We were able to prove that there was significant anticholinergic toxicity in the case. And we were able to show that she was getting better. So that ended up being the end result of our review, was not just helping them get better, the patient's living better, the symptoms are going away, but we were able to help her live and stay at home instead of paying close to $12,000 a month for a memory care program. All right. So deprescribing, I feel, has such an impact on not just families, but I believe the entire spectrum of aging. And so our efforts collaborate with physical therapists, occupational therapists, psychiatric providers, care managers, to really address the burgeoning problem of polypharmacy. The beauty about our relationships with our clients is we just keep that ongoing touch point and we build rapport. So we're having biweekly check-ins. We're collaborating in care with the providers. We're sending anything new that may happen. If there's any withdrawal, if there's any new symptoms that may come about, we're screening and assessing in real time if there's anything else that might be worsening quality of life, because that, my friend, is the ultimate goal, is making sure your loved one is living her best days in her final years. We also are huge proponents of genetic testing, or pharmacogenomics / precision medicine. One of the first things we got covered was our certificate in becoming pharmacogenomics consulting experts. And so that way we like to use precision medicine to help advocate for any deprescribing, especially as it relates to psych meds and other conditions that are relevant to genetically actionable drugs. And the FDA has a list of FDA actionable genetic drugs right on their website. And there are tons of awesome resources that we also share to help clinicians figure that maze out. So to be fair with you, I had no clue that this one case would lead to this journey of advocacy and general, really just teaching about the art of deprescribing. We know it's not, a cut and fast type of hard science. There's definitely something that is going to be based upon patient response. But I really found my niche, and I got my love for informing people on how they can advocate for themselves. I don't care if it's, opioid deprescribing or dementia, or maybe in some cases herbal, right? It's just making sure people know that there's a time and place for everything, but with good prescribing comes the very same good deprescribing, and they both work together. Okay. So we had a couple testimonials. We've had some powerful moments where we've solved some complex issues for care managers who didn't realize, hey, this new diabetic med is actually why he's having so many UTIs. These little things that I feel sometimes as pharmacists we can catch, may not come as easy to, say, a caregiver who's overburdened, or a care manager who's, just isn't trained in the world of pharmacy, right? But they generally deep down know and feel that there's something funny about the medications. And that's why geriatrics has become one of the leading voices in helping these providers navigate those waters. Okay. So this, to my eyes, benefits everybody. I don't think we need to preach to the choir that we're all on board with how do we start with addressing polypharmacy. There is no one cause, right? We know that this is a systemic issue. We can absolutely have, better policies talking about reimbursement of clinicians to have med safety deprescribing consults, or maybe better ways to train people about how to implement this in real time. And we'll cover a few of those steps in the next coming slides. So I'm a huge proponent of non-pharmacological approaches, right? So I love the work of the ACLM, the Academy for Lifestyle Medicine. They do have tons of certificate training programs around how do we address the mind-body-spirit relationship, how do we address diet and exercise, stress management, deep breathing. They all can be excellent tools. And I feel we should use them more. I think we're quick to kind of say diet and exercise, but we don't really give patients and clients the real tools to implement it. So one of our cases later on, we'll share how the use of some of these non-pharm approaches became the bedrock of our care. But a lot of what I like to coach our students and our patients and our clients is at every visit, at every, chance you have with your provider, ask, what can I do today to get off of one or two meds? If you're on quite a bit, or if you feel, it may be time to just have a general discussion. Ask, what are the risks if I stop a medication? What are the benefits if I stop? What are the risks and benefits if I continue? This should be a shared decision made approach with your team, not just in a silo, right? I've got clients who hire us, and, sometimes they change their mind about whether they want to stop something or not. It's not my job to force my opinion on them. It's to give them an informed opinion on what they can do, what the risks are. And if they change their mind or want to try it again later, we can absolutely do that. All right. And I think a lot of this should encompass the psychology of medications. Like, what I mean by that is the relationship people have with medications is a deep-rooted one, and it should not be taken lightly, right? All because I come and say, this is causing this, you should stop. It does not mean someone's going to stop, right? Especially if we're not talking about, the timeline they've been on this medication, or the autonomy that some of our older adults may feel could be put into question if, someone's just slashing 3 other meds and they've been on it for 30 years. You have to address that, because a lot of this is addressing indoctrinated mindsets from, the general status of being an American, right? We got pharma commercials everywhere. We've got drug commercials everywhere. We've got the next new song and dance is the next new diabetic weight loss drug. And there are tons of people who believe that what that is the reality. And it's not to dissuade or dispel the impact and amazing value medications have had in society. That is not to be questioned. We know that we're living longer, better, and faster with the use of meds. But how are we employing the safe use of meds for each and every person, right? Most clients are coming, there could be one small issue, you're on one new med, and now that leads to another set of issues. And it ends up being a more reactive approach than a holistic functional approach. So again, is this medication absolutely vital and important for me or my loved one to live with? Do I still need this at every visit? Have a positive discussion with your provider, okay? So I always like to give homage to Mildred, who had similar issues to our first patient case. But that pharmacist worked at Rite Aid, and she took that time to stop what she was doing, listen to my mom complain about her getting worse, even though she's doing all she can, and getting that antipsychotic medication stopped, which, yes, FDA black box warning to not use this in specific cases with dementia and psychosis, as we know that the FDA black box states that there's an increased risk of cardiovascular mortality or stroke with the use of the medication. So Granny, once we got that medicine stopped, had her symptoms subside in about a month. And my family, my parents were able to move her back to a different facility in New York where she gracefully aged to see the beautiful age of 90 years old. All right. So that was a huge blessing for me. And to have her die essentially on my very, very last day of pharmacy school, I think was a huge testament to that pharmacist who saved my grandmother's life. So like what we saw in our previous case, there were tons and tons of examples of prescribing cascades. One example being the use of tamsulosin, which was managing bladder retention. She was on a number of drugs that would have led to anticholinergic toxicity. And a side effect of having that would be, of course, having some of that water retention. All right. It's keeping her from urinating. And we had quetiapine, we had Benadryl, we had some other allergy medications on board. There were a couple meds on there, and her score was about, I want to say it was about 9, if I'm recalling correctly, which is high, more than 3 on the anticholinergic burden scale. And guys, you could check out acbcalc.com if you ever have a loved one with dementia or signs of dementia. Look and see what her anticholinergic burden score may be. All right. There are significant drugs. It could be one, it could be a combination of many, but have an idea of what that calculation is, as it can signify increased confusion, falls risk, hallucinations, etc. And it can almost mimic signs of worsening dementia. And the goal, again, is to help people stay and live at home. I wanted to share a couple of resources we commonly use when it comes to our prescribing consults. Of course, we start with what matters most to the patient using the 4Ms approach. We then, depending on the case, we look at anticholinergic burden scales. So that's through acbcalc.com, which I have listed here. I'm a huge fan of medstopper.com. You could plug in a bunch of meds. It can kind of give you a sad face or a happy face based on the severity of which drugs to target. Of course, you can always rely on the American Geriatric Society Beers criteria. They update this compendium of over 200, 300 drugs, and they give the rationale on why certain medications should be avoided in certain populations. from everything from kidney function, liver function, of course, high-risk meds, our benzos, our opioids. The AGS Beers criteria is an amazing, freely accessible resource. So if you're a clinician, I absolutely commit that you have that memorized or have a quick link on your desktop, and be sure to check it out. We've also got tons of other guidelines that are out there. Of course, the amazing deprescribing.org has a number of guidelines on deprescribing, from your proton pump inhibitors to your dementia medications like memantine and donepezil, to certain psych meds, benzos and antipsychotics as well alike. But they've got tons of resources. They've got patient videos. They've got algorithms. Go to deprescribing.org. They do have grant opportunities as well. So say you're passionate about deprescribing and you want to bring it into your practice or consider collaborating for research. They do offer grant opportunities, and they have deprescribing research groups all over the world. I had no idea until I started looking into who else was doing this. And we've got, Canadian research for deprescribing. We've got Australian. We've got one in Europe. There are tons of awesome, amazing researchers in this space who are advocating and making this become the standard of care. All right. But one thing I'll note is, in doing this, listening and empathy just go so far. A lot of what you'll uncover comes down to what people are feeling and are they being listened to. And they don't often get someone to just sit for an hour or an hour and a half and just listen to what they're dealing with and their journey behind each of these medications. There's a story behind most medications that people are on, right? Sometimes it's a short one, like I was admitted to the hospital and I never stopped that medication that was prescribed, right? Or maybe it was an issue that is ongoing, right? But there's a story behind this, and how people feel about the medications, how people feel about their care, all of these things play a role. So I want to make sure that if you want to bring this to the forefront of your care or your service, that you're learning how to be an active listener, you're learning how to lead with empathy, and you're learning how to really just understand the basics of connecting with your client. And this should not be a patriarchal, do what I say. This should be a shared moment, as sometimes just talking about the medications can bring about emotions and vulnerabilities that you just can't see from a med list. Okay, so just wanted you guys to have a sense of what that can look like. But we know that there are tons of benefits. There can be, hopefully some reduced costs, some reduced utilization of health services. And we want to make sure, of course, we can be that resource for you all, no matter where you are in the country. If you're a clinician, if you're a patient, we help anyone who needs support. So I just wanted to list my office number, which I'll put in the chat. I also wanted to briefly touch on a more recent client that came to us. This was a 72-year-old woman who presented with a left-sided stroke. She had been on Klonopin since her mid-30s. And so during her younger years, she was diagnosed with these paresthesias that would affect her sleeping. And so her feet just could not really stop moving. So at the time, there was an appropriate indication for Klonopin, but she had been on it for pretty much 4 decades. And these were Klonopin, it was about 1 milligram twice a day doses here. All right. Additionally, she had some herniated discs. She had some failed back surgeries and had been on long-term chronic use of oxycodone and OxyContin after having a couple of hip and knee replacements. Of course, now we've got chronic pain in the picture. So that has a high association with depression. And so it was also treated with, I believe, Cymbalta at the time. And she had a horrible reaction to the medication. She was having severe brain zaps and essentially had to get readmitted because of her response to that medication. She also, from her stroke, which happened in 2021, she also had some pretty severe aphasia. She was only maybe getting out maybe 3 words, and they were all very much spaced out. So it was difficult to really know what she was saying or emoting. Her husband came to us and wrote us a letter about, well, how her wife has been, the clinical journey. Her main concern was her energy, her pain, and addressing the fact that she was sleeping close to 15 hours a day. All right. So I would love to know, just from this kind of brief synopsis, what you guys might be thinking, what's going through your heads. Are there any specific combinations that are of concern to you as a clinician? What are your thoughts? Now, I want to go ahead and also show the initial medication list. When we met, this case happened as of last August, and she presented with Klonopin 1 milligram twice a day. The husband noted that she became fairly dependent on it. She basically knew what color it was, what it did, and she would go into crying spells if she did not have it around the clock at that set time. She also was on ezetimibe 10 milligrams, Crestor 20, metoprolol 25 for her arrhythmia. She had some arrhythmias. Telmisartan was recently added along with amlodipine for blood pressure control. Liothyronine and levothyroxine were taken together. She was on oxycodone at one point. She was on oxycodone 10 4 times a day. When she came to us, she was starting to taper down. So she started around 3 times a day, and we started working with her to get down to 2 a day. She had some other RA positive findings from a while back, but really it was unclear what type of autoimmune disorder she had. So the folic acid and methotrexate were on board, but as I was meeting them and they got on board for our prescribing retainer services, the doctor was already in accord of tapering off the methotrexate over a couple of months. Aspirin 325, not sure if that was necessary post her condition, but she did have, a major intracranial blockage. She was on a couple vitamins for B6, B12, D3, mag oxide, as you can imagine. She is constipated and has been on chronic steroids for quite a while, along with the use of naproxen twice daily. All right. So to the clinical eye, there are, of course, a couple of things that do jump out. But I would love to know if you have any thoughts or comments. What kind of makes you cringe, or what are some things that you would want to talk first? So the husband, of course, came to us a bit distraught. He's an older gentleman and the only one providing care for his wife, right? She was very intelligent. She still is. She's a psychologist and just had a rough go at things. So that being said, after her stroke, she had a lot of left-sided weakness, difficulties, saying how she felt. She had a number of crying spells. And so we had a number of in-home visits to see what we can do with our deprescribing services. First and foremost, we had that initial consultation identifying which medications may be potentially harmful for our patient case. With her, she had naproxen on board, right? So as a pharmacist, chronic NSAID use, I know she's in pain, but the use of NSAIDs would be contraindicated in someone with a stroke and heart attack history. So that was a big one we had to address, as it was kind of her best relief came from naproxen. We ended up focusing on the clonazepam. Why? Because what mattered most to the family, to the husband, was getting her energy back. And we know clonazepam can have such a long hangover effect. So in approaching this, I love the Maudsley's guidelines. I didn't know how aggressive to go with this taper. I will say at first, I had to phone a couple friends from the USD Prescribing Research Network to see, how can I approach this? And eventually, there was an algorithm where we were going to convert to diazepam, as Motley presents, and do super micro tapering, right? And it just wasn't really practical. I mean, the guy was struggling to split a tablet into quarters, and getting the diazepam on board and trying to find liquid conversions. He was like, look, I don't have the bandwidth to micro taper, frankly. He just couldn't do it. So we knew that there could be significant rebound. There's, a woman's been on it for 30 plus years. She's also combining it with opioids. We've got huge high risk for falls, huge high risk for CNS depression, and we've already seemed to have some signs of dependency on the medication. So this could be a little tricky if we were to taper and maybe there's an underlying anxiety that comes about, right? But in working with her, in order to help alleviate some of these concerns and issues, we use a bit of our lovely non-pharm. And so what I pride myself with is partnering with other specialists in this space and having a myokinetic healer or advanced massage therapist who helped with unblocking parts of her nerve channels with deep massage and doing other exercises around the home was critical in mitigating some of her pain and keeping her calm. Additionally, this person was specialized in eye patching, eye yoga. I did not know about this, but essentially it was to help re-strengthen some of those brain and neural channels in strengthening that weak left side and essentially blinding the other side of her body, her eye or right eye, for example, and helping her read cards with the left side to work on how her body compensates when one eye is closed. Again, helped in her ability to eventually read. We got her involved with a speech therapist and, of course, continued exercise, aqua aerobics, and acupuncture. Did everything we try work? No. At one point, the acupuncture realized that he could not continue based on the severity of the bone damage for the pain she was having in her shoulders, which was why she was on her chronic opioid dosing, right? But the exercise, the eye patching, the massage therapy, all of these helped us augment our services and reduce the need for the clonazepam. It took us about 6 months, but since as of August and at the beginning of, I'd say, mid-March, she was completely off the clonazepam. She had no withdrawal issues. We did, very low and slow at first, and then we just kept going, but there was no resurfacing. There was less napping all day. There was more energy. And this was all done under the supervision of her providers as well. So a bit of the work, but a huge success. She was coming back to normal. She was speaking clearly and better. She had brightness in her face and her eyes, improved communication. She was more active and proactive. She was planning trips with her husband. She was having better care and just was herself again. And so it got to the point where the primary caregiver was crying at the amazing success. Her family was talking to a whole nother person when it came to Christmas that year. Towards the end of our time together, we were able to taper off 8 medications and more to come. So currently on about 12. She was initially on about 20. A number of them we were able to reduce or just remove. There were some duplicates here and there. Her cholesterol was stellar, and her risk, her lilothyronine, again, just wasn't really needed. She had a lot of elevated pressure, I surmised, from her chronic hydrocortisone use, along with her ongoing pain. I think that was spiking some of her readings. Beautiful. I want to thank you all for your time and attention. And again, a pleasure to be here.
Thank you, DeLon. One of the things I wanted to point out was the people who are in the chat are very much concerned about tapering psychotropics and the problem of withdrawal symptoms. So I wanted to, as you can see from DeLon's 2 case studies, that he is dealing with people who are taking a massive number of drugs. And many of those drugs are not psychotropics. So when he says that he reduces the drugs over a couple of months, we're talking about possibly taking away the drugs that are not psychotropics. But that does leave the problem of tapering the psychotropics. Also, when someone, we're looking at a very vulnerable population here, and when they have been classified as having dementia and are basically incapacitated from having normal lives, taking 30 drugs, it may make sense to remove those drugs rather quickly to restore their abilities to really just function as independent human beings, even with the risk of withdrawal symptoms. However, we are concerned about withdrawal and we are concerned about tapering. So we have some questions here for you along those lines, DeLon. Let's see. How do you facilitate? So we know that doctors are sometimes hesitant to continue writing prescriptions, let's say for benzodiazepines, but the patient really needs to have, say, graduated doses in order to taper off properly. How do you handle that conversation?
Yeah, no, it's not always easy, and especially in that previous case, there was clearly signs of dependency on it, right? And there were some times where, we had to just repeat the same thing over and over again. And a lot of it was, saying, hey, we're not changing your medicines. We're just we're tweaking the timing of how you take it, right? Or maybe we're reducing the dose gradually over time and seeing if we can get you on the least effective dose that still helps you out. And that can still cause a little bit of consternation, a little bit of fear. But a lot of this, again, especially in a situation here where sometimes the patient didn't know or couldn't communicate, with the aphasia and what was like necessarily what she wanted, it was a hard line to draw of like, where do we take deprescribing versus, look, you're on very high risk meds and you have a falls risk, you're walking with a cane. At what point, does one supersede the other? But in this case, we brought the evidence to our provider. The provider was completely on board. We were communicating and saying, look, we're going as fast and as slow as you want to go, but we're letting you steer with provider baggage. So if you want us to go back, we can go back to the drawing board. We could slow it down. We can start to where you were. But again, it's ensuring that we're leading with empathy. And yes, there may be some initial grumbling, a little bit of fear, but we had the provider buy-in, and a lot of it ended up being continued. Hey, let's try this again and see where this goes. And we kind of base it on how the patient response. So it's not easy. It's just kind of feeling out what's working.
So you have to actually negotiate with the patient as well as the provider. It sounded like in the second case, the woman's husband was cutting up her clonazepam tablets, right? So was that a situation where you were advising them directly and not going through the doctor in order to titrate the drug?
No, everything we do includes the provider. So as we were working those processes out, the provider, gave us like an easy to adjust form of Klonopin. So if we had to order a surplus and help with the splitting physically, we could. So the provider was completely on board with the plan. I developed the tapering schedule. We came up with the patient together with what the plan would look like if it's feasible. And then we brought that to the provider and he got the buy-in from him. So yeah, at that point we had his buy-in.
So you had you had an overview of all of her drugs and you provided a rationale for why certain drugs would be removed according to, let's say, the Beers criteria and the anticholinergic burden scale and so forth. And the provider, I'm presuming that you're talking to like the last treating physician. And this is like what you're seeing is the result of a whole history of prescribing cascades, right? Yeah. So he's kind of doing the best that he can. He or she is kind of doing the best that they can with, like with a legacy, with her whole legacy of drugs, and probably, like kind of throwing up their hands at like, well, I can't figure this out. I'm just going to continue this from, wherever it came from, right? So
if the patient's husband did not bring up this issue, it would have been a higher dose in the same situation.
Yeah. So they're, like, while recognizing that that's a lot of drugs, because that provider is still writing the prescription, so they know that there's a lot of drugs involved. So while knowing that there are a lot of drugs, the providers just kind of don't really have the time or the focus to figure out what drugs to drop. And so when you tell them about, let's say, drug duplication or excessive anticholinergic burden and such, then they are receptive because you have the scientific documentation for that. Is that right?
They're receptive to that. They're receptive to the fact that someone's lending an extra eye that, again, they don't have the bandwidth to. And in the long run, it can also be a liability. If we show that this is leading to more harm, and they see that they're liable because they wrote the order, that they often change their tune. So, yeah, a lot of ways.
So ordinarily the patient or the patient's caregiver will contact you, and then you'll be able to establish a relationship with the provider afterwards. Yeah.
Yep. We work with the patient. We're now working where we're partnering directly with prescribers. We're going to pilot this at Duke with their geriatrics division. So that was the original model when we started, but now we've got a lot of demand from providers to use this service and refer it. So
that's perfect.
Now we're focusing on physician offices.
How is that going to work? Are you going to produce continuing education for them?
We've already done so. Yeah, we've done grand rounds discussions. We've done CE trainings for their primary care providers and the geriatrics division. But more intimately, we'll take a referral from them. So they'll send a referral from the provider to the patient after discharge, and we'll be able to work with their patients collaboratively.
Oh, well, that's really excellent. So you'll be able to do the med reviews. So you're basically the specialist doing the med reviews. That's really helpful. Can you get insurance coverage for that, or is that also an out-of-pocket service?
Yeah, we're working towards that. Currently, it's a cash pay model because that's the world I'm in presently. But there are ways to make it a billable service. I'm just still exploring.
Right, I know it takes a long time to figure that stuff out. Now you're not able to prescribe directly. Is that correct?
No prescribing.
Okay, but you can give the doctors tips about how to write the orders. Let's say, do you do much guidance in terms of giving them, telling them how to write a compounded prescription?
I don't, but I can. I've gotten maybe one or two of those interesting cases. Had a person who had like a chronic itch at the base of her neck and had to require ketamine and amitriptyline and lidocaine compounded for that. And we've given guidance around it, but it's not something I see every day.
Was that a cream a topical application with amitriptyline?
It was an ointment.
Okay. Okay. Here's another question for you. Would you provide services for people younger than 60 and out of state?
Yes to both. We've had a couple of middle-aged adults we do reviews for. I think it's nicer to get them off early. So as long as they're not pediatrics, we can help them.
Yeah. I always say people have a habit of getting older. So everybody's potentially geriatric.
Right.
Yes. Okay. All right. So in your locality, can you recommend any place that is responsible for compounding? That would be a pharmacy.
I would look up a compounding pharmacy nearby. I don't know if they're referring to my location or where they're at.
You're in North Carolina. It's really unfortunate that doctors in general don't get a lot of background in pharmacology, but on the other hand, pharmacology has become extremely complicated, and that's your training, right? You are the expert in the not only the drug action, but the adverse effects that might come from the drugs. Is that right? So you're probably, so pharmacists such as yourself are probably much more knowledgeable about that than a GP, because that's the focus of your training. So you're finding that the doctors are actually appreciate your input on that. They probably are feeling pretty overwhelmed.
Yeah, no, they are appreciative. And I've had one even state, we wish we had you for all of our clients, from a Duke primary care office. So doctors see the value for sure. I think everything in this space just requires a team approach. We just all need to collaborate. We all have different skill sets and gifts. You don't want me diagnosing something. You want me figuring out the treatment, right?
Yeah.
So I think they all are complementary to each other's skill sets for sure.
So our audience is really concerned with, let's say, deprescribing antidepressants and benzodiazepines. I see your cases also seem to there are antipsychotics in the mix. What do you see in terms of withdrawal symptoms? Because in terms of what we know about tapering, it seems as though these drugs might have to be reduced very carefully. So, and you're seeing people ordinarily like every 2 weeks, is that right?
It's concierge, so we have 24/7 access. So if there's something that comes up, people can reach me. But we do have standing check-ins for sure to see where things are going. We've helped a psychiatrist in the area figuring out how to taper from what was it? What was the medication? It was one of the newer antipsychotics for bipolar. I'm actually drawing a blank on it. But she ended up having too much tardive dyskinesia. Forgetting the name of it. It was a new drug, but too much TD, and she was doing okay with like a minimum dose. And also there was a genetically actionable issue. So we found when we did a genetic test that she was a poor responder, which was also what happened in our case presentation. She just genetically could not clear, and that ended up being the answer to why she was more sensitive tapering. So anything with psych, I love to advocate for getting a genetic test done, see if your provider can get it ordered and covered. It is usually covered by Medicare and Medicaid in some states and some private insurers, especially if you failed a couple of regimens. So I like to just have an idea of that before just going into hyperbolic tapering and all the fun stuff.
Yeah. What vendor do you find most reliable?
A lot of them are good. I don't want to say which one because there's so many good ones, and it might depend more on where you are. If you're going to order it, it might be easy to go local. So I can't put a name on it, but there are a lot of good ones.
So when you analyze the results of genetic testing, how does that affect your recommendations?
It actually enhances it. It gives people a clear report, clear evidence that states, hey, good, okay, avoid, clear is color coded. It really amplifies the work we're doing and getting down to the root genetic basis of our clients. So patients, families love it. They love seeing it. Then they get curious about testing themselves. And then providers get a nice actionable report. Now, we need to find better ways for people to, remember to access that internally with EHRs. But at the end of the day, that makes my job a little easier because now I have, proof or some, rationale behind why I think we should go a different route or even help them prescribe a better option that's less genetically actionable.
Right. So the genetic testing is going to indicate potentially which drugs are causing the worst adverse reactions because the people will be poor metabolizers for those drugs, right? So they won't be able to metabolize those drugs very well and therefore experience more adverse reactions because it's somewhat of a buildup in their systems. Well, that's that can be really helpful. And of course, I think probably the doctors really like those types. They like the data-driven decisions, right? One of the things I was wondering, both of the cases that you reviewed, those people were taking a lot of drugs. Each of them was taking a lot of drugs. Did you find that they were fast metabolizers? Those are enormous burdens.
No. For that second case, it was a lot of poor metabolizer. There was two major pathways were poor, and that's why it helps to have a pharmacist talk through this, because you could be poor and have no active drug come at all, and you're just getting, say, the precursor drug before it's active. So we call those prodrugs. And if you have a prodrug and you're poor, you're not getting active drug, you're getting the prodrug form, and it can lead to more side effects and issues. Yeah. So, and then of course, there are also drug-drug interactions plus drug genetic interactions. Right. So you can have two normal, one poor, and that can make the whole thing intermediate or something.
One drug can block the metabolization of the other drug. How about, these two cases, I think that, and this is, of course, this isn't the first time that we've heard of this, where people will, when their medications are reviewed, they're taking dozens of drugs with a lot of duplication, and it's amazing that our bodies are able to handle this long term, but of course, both of these cases, what's happened is that they've, that drug burden has actually incapacitated those people in some regard. Their digestion might still be functioning, but it's, but the end result is that, they can't talk, or they can't, they lose things, or they don't understand what's happening. It's really a tribute to how strong our bodies are to take care of all of that. And it's also really, quite heartening to hear that there was such significant recovery after removal of the drugs. And I think that this is something that's really important. So a lot of people are taking maybe one drug, though, and having those adverse effects, but they don't know exactly, they can't really tell what's happening, right? So would you deal with someone who's taking one drug and has questions about the adverse effects?
Yeah. We'll help anybody, honestly, who's in need of clarity, much needed clarity, right, in their journey of healing. So if it's, we've taken clients with just 3, 5, and we just help them out and don't charge if we don't need to, but we want to help anyone who's looking for that peace of mind.
Right. Well, I think that even having guidance in understanding the genetic testing is really helpful too. I think that we've come to the end of our questions, and thanks everybody for attending. Thank you, Dr. Canterbury, for visiting with us.